I'd like to welcome everyone to this webinar. This is an initiative by both the social sector PPP's chapter and the technology and artificial intelligence chapter at WAP. And this is the second in a three-part series, mini-series that we're doing on AI and digital health in the health sector, and how that can be structured as PPPs. The topic today is benefits of and challenges with implementing and adopting digital health and AI in healthcare. And we're delighted to have really a good lineup of panelists to be joining us. And of course, with Thibaut as the moderator. Thibaut will introduce himself some more. Thibaut is a founding member of WAP, and amongst other things is the chapter head for technology and AI. So over to you, Thibaut. I'm going to go off video to facilitate the entry of our fourth panelist.
Thank you, Nasser. I'm a PPP consultant, WAP co-founder, head of WAP editorial board, and I'm also chair of technology on AI chapter. And in this capacity, I co-organize this webinar with the social sector headed by Nasser. So I'm very glad to be here. And I will follow up with some additional questions and also transmit the audience. Thank you.
Hey, Tamara, Dr. Tamara, thank you for joining. And we understand that you have a very specific circumstance that you're joining from. You are masquerading with Dr. Varun Goyal's name as your title, but that's not going to change anything. Over to you. Please take us through your initial presentation. Thanks.
Mayor, you're speaking, but I think you have to unmute yourself below in the left corner.
Oh, sorry.
Now we hear you perfectly.
Yeah, great. So this is the futuristic city of Neom, if you could look, and this is not generated by artist or studio or design studio. This is actually generated through prompting, through Gen AI. And this shows us that AI is in things that we never knew existed before, like art and creativity. So what used to cost millions of reals to produce can now be produced with this touch of a button with a simple prompt. Okay. So we all know that ChatGPT is doing really, really well. And this is just an example of how it's improvement of ChatGPT 3 versus 4, and now how it's even outstanding regular human performance in a lot of the standardized examination. And we thought that was the end of it. And last September, OpenAI released Strawberry. And Strawberry is the new generation built on Star Network. And that means a lot for healthcare, because that means for health, it's more deeper reasoning and more contextual. So that's a big game changer for healthcare. And just let me put it for you guys in context. So how smart is that? I'm going to remove this because maybe this is in the side. So see this guy down here? That's Einstein. So look at where O1 is. That's Strawberry up there. So it's going into places we never knew it would go before. I want to ask you all, by a show of hands, how many of you would be okay having this robot do surgery for you? By the way, this robot is available in all most hospitals. So do I see any hands who would agree to have this done by a surgeon? All right, well, what if I told you the surgeon had AI and it wasn't actually a surgeon? Would you still be that comfortable? So this is a recent study from the NHS, and it's showing you how robots med surgeries could actually boost efficiency and free up beds. They actually noted better outcomes because what happened? Less blood loss, less surgical infections, and even shorter hospital stays and faster recovery. So it's actually really improving the way we deliver care and at least surgical care. So that question for you all is, are you a doomer or are you a boomer? Do you think this technology is going to doom us or boom us? Well, let's think of it contextually. How many of us, we know that on each airplane flight, there's definitely, there's a co-pilot, there's automation, and there's things that help guide the pilot as he is flying. And similarly, this is how we think of technology, and it's going to enable healthcare. It's going to be that co-pilot for the physician that's not taking over, that still gives that physician control, but actually gives him the constraints. He doesn't have, so doctors don't have time to read charts, do multiple tasks. So this one prepares all the data for him, so the doctor can make that decision and listen to what the co-pilot says, because it might have different insights because of the bigger picture, and we'll let the physician know. So I'm just going to go quickly for 10 lessons, and these are things that we need to be wary of when we're implementing healthcare, because it probably sounds so good for you guys, but we have to do it within certain constraints. So I'll start with lesson number 10. So lesson number 10, deploying AI with strategy is like building a rocket with no destination. It's impressive, but dangerous. So it's very important to set organizations that they set their strategies, right? And especially in the realms of PPPs and as we're rolling them down. These kind of the use cases have to be very clearly thought of, and how we're doing it, and then all the constraints of those use cases and what we're trying to accomplish, and the validation of that. Lesson number 9, insight alone doesn't save lives, response does. One important thing is the insight, when the AI tells you what you should be doing, does not equal outcomes, because if the physician doesn't know what to do when he gets the AI alert, or the nurse doesn't know what to do, it's not going to take us anywhere. The next one, and for this one especially, prediction is potential, but protocol is power. So for each of those AI algorithms, it's very important that institutions have those protocols that when they launch them. Garbage in, guesswork out, because these AI algorithms are as good as the data it feeds. So as we implement these PPPs, we can't just take an AI algorithm that works towards some solution that works to just solution in one place and put it in another, because data is very contextual. So if those AI algorithms are not built on the right population, they're not going to work. And prompt engineering is training the people, not just the model. So we heard about all these large language models and how they're improving clinical workflows and helping clinicians. But for this, training is not optional, it's foundational. It's the way you speak to the model, that's the output you get. I often equate this to speaking to for a husband speaking to his wife. Now, if you want to get something, you're going to know the tone, how you say it, how it matters. That's going to bring out the response from the model. So training is foundational to having any large language model. And then the next here session is equity, right? And I think as we, of course, implement these PPVs with AI, we really need to remind ourselves that AI that's fair for some, but flawed for others isn't fair at all. And the equity is not a checkbox, it's a design principle, because if it's not coded in, it's coded out. It has to be embedded from the get-go. Lesson number 5, from game changer to checkbox, AI is now part of the pack. And remember all the old days when we used to have something we said we have mobile enabled. Would you now buy anything that's not mobile enabled? Of course not. And the same thing will happen with AI. Nobody's going to buy AI in the future if it's not embedded in the workflow, if it's not part of, it's coming in with the system by default. So we're going to see less of these separate, deconstructed AIs coming in the future. Number 4, AI cannot work without a runway. It's playing up by infrastructure, data, and people comfort. So if you have a wonderful plane and it doesn't have all these runway, it's not going to fly. Similar for AI, it has to have the data that's validated, that's accurate. If we feed it data that's flawed, skewed, doesn't include the population we're running it for, it's not going to work well. Similar to infrastructure and similar to people that understand and that this is embedded in their workflow and they understand how to work with it. And then next lesson, it takes a village to build AI, but policy, tech, and health must work together. So all three needs to be aligned. Policy needs to be there as a constraint set by the governments. Then comes the technology as an enabler. And then health is the one that shapes it, right? So healthcare, the clinical teams are the ones, and the clinicians and the hospital systems, they're the ones who shape what they're gonna want to get. Lesson number 2, building with intention, not just innovation. It's very important. Just same as what we said with equity, ethics is very important. The purpose, the ethics and the vision. Why are we doing this? How is this going to be effective? Are we going to harm anybody? What's the carbon footprint of this? All the stuff is, needs to be also built in from the get-go. And the last lesson is strategy isn't slow, it's how you go faster. So you don't, strategy is not an afterthought. It needs to be there from the get-go. So, and how a phased roadmap turns readiness into results. And here are the things that we need to start off with. First of all, you start off with your baseline audits of where you are today, engaging the stakeholders, scaling sustainability, auditing AI projects, and having those strategic roadmaps that show you the way. So I'll close here by saying success in AI is not about algorithm. It's about solving real problems that last, right? So it's about the solutions and how they're embedded in the workflow and how they change the way we run our business. It's not something that you get on the side to help with things, because if you have it decentralized and you're not using it within your system, nobody's ever going to go and refer to it. And so I'll close with saying, let's embrace a sustainable future in healthcare, and where all these things come together, because coming together is a beginning, staying together is progress, and working together is success. And definitely see so much big potential for AI and digital health technologies in PDP. Actually, it's probably the next best use cases that are going to come out there. But let me caution you all again. Don't cut paste. You cannot. It's not like you can cut and paste it from one area to the other. Make sure that the population that it's developed on is actually remodeled again for that population and validated and checked through. And not a one-time check, continuous check. So I like that. I'd like to thank you all. Thank you very much. And if there are any questions.
Thank you, Tamara, for this brilliant overview of AI landscape in healthcare. May I ask you a question? What is, in your view, the most important barrier to generalization of AI? Is it technology with its current potential but also limitations? Is it regulatory, or is it the...
So the regulatory is very important. Okay, that's one of the things, because I think it's a lot of countries
human
putting
factor,
on this.
both from the acceptance of for...
Hello?
Hello?
Yeah. Hi. Can you guys hear me?
Yes.
Okay. Yeah. So so it's a multitude of things. Of course, regulatory is very important, because I think there are countries that have regulations. I'll tell you about Saudi Arabia, actually, and they're published, by the way, free of charge for people to use. So Sadaya came out with their AI regulations, the AI ethical framework. It's all there to be looked at, and you can have a look at it and see. But countries need to do that. So when people implement these things and you start having PPPs and things like that for these, they know what the guardrails are and what the restrictions are, right? So I would say policy, and that was some of that where that policy, tech, and people come together. So policy would be number one, because you can't do anything without that, right? What if things go wrong? Who can be harmed? Do we have to get these FDA approved? Who's the local entity in our country that's going to approve them? I'll tell you, for example, if something goes wrong with the AI algorithm, we report it to the Saudi FDA. It's just like a medication that you're using, right? So you have to have these guardrails in place. So first of all, policy is number one. And then people, again, it's about that data. It has to be very contextual. It has to be validated, revalidated. So even though it has an FDA clearance in your country, still you need that revalidation. So it's having those people that know how to do that revalidation and check. And as well, if I had to choose one, I would say policy and regulations. And if you guys want to look at that, like I said, Sadaya SDAIA has a beautiful website with all of this detailed in terms of ethical frameworks as well as their AI governance policies for the country.
Well, that's great. Thank you, Tamara. I would like to encourage all participants to ask their questions in the chat box. So if anyone has a question for Tamara, quickly, Tamara is very tight schedule. But otherwise, Tamara, thank you very much. And
thank you.
I think these were very enlightening presentation
Thank you.
for everybody. So we now go to the next speaker.
Thibaut, can you announce the next speaker? The data where you are is really quite weak, so we're not hearing everything. Can you announce the next speaker, please?
The next speaker will be Stefan Lazarevsky. Stefan, the word is the floor is yours.
Thank you, Thibaut. Thanks for giving me the floor. Thank you, everybody. Good afternoon to your participants. Thanks to Nasser and Thibaut and the whole VAP organization for inviting me and talking about this important matter. I have as well some presentation that I would like to share with you. Hopefully you can see it as well. And I'll just go back to the beginning. Just some notes that I made so it helps me out to come through the presentation. Yeah, let's not waste too much time and start with the reasons behind. You've touched on the reasons behind in the first webinar. I've heard about that. You have it posted on YouTube. So I really like the first webinar that you had maybe some 1-2 months ago. I always say there must be a reason that triggers technological innovation, and this qualified staff shortage. It's one of the reasons. You touched on it, as I said in the last webinar. There is a lack of qualified staff shortage. The countries are, let's say, fighting over qualified, and qualified is the keyword here, medical staff. Then there is demographic changes. People are getting older, over 60, 65. These people are in need of special medical treatment. So there is different patterns of diseases that this changes constantly. So all of this is triggering technological innovation in the healthcare. And on the other side, if you see, on the other side, if you see it, I don't know if you still see my presentation. Perfect. On the other side, if you see the government, which is the traditional public provider of healthcare, they lack the know-how of these technological innovations. It's difficult for them to catch up. Not only the know-how, in many of the countries, they even lack the financing as well. So I'm saying this is why that maybe public-private partnerships could be a solution that that helps to implement AI solution and digital healthcare in the health sector. So I believe that this is triggering it. And when you invited me for this webinar, I was thinking about the healthcare. Healthcare sector is very broad, and me working for the Siemens Healthineers, I touch on some of the topics. But if I consider the cancer treatment, I would say it's one of the topics that really is the most challenging to be handled nowadays. As it says here, 18 million people on the slide, as it says, 18 million people are diagnosed with cancer annually, and this number will basically increase by 2040 to 40 million. This was done based on the research of cancer research in the UK. So I always say if AI and together with the PPP model, if they can beat cancer, they can face anything. And in order to show you how this could be used. I thought to provide you with some use cases from the past, from my experience that I've had working for Siemens Healthineers in PPs that have implemented AI solutions, and they have basically solved some of the matters. So the first use case is coming from Finland. It's the first one of the first public-private partnerships in this country. And basically the need of the hospital Nova in central Finland was that they really needed some efficiency and training for their staff in the imaging department, and they were looking forward to have one supplier. This is very important in this project, that they were looking forward to have one supplier. Siemens Healthineers provided them. They provided them the usage of single software, TeamPlay and DeepResolve, is basically are all AI programs, some of them for the precision imaging, some of them for the prioritization of patients, and others for timing as well, and faster imaging. So all of this was implemented through this public-private partnership through one supplier, Siemens Healthineers, and the PET scan times were reduced from 25 to 10 minutes, so there was much less waiting times. And if you have done, unfortunately, some of you have experienced PET scans, they are very uncomfortable for the patient. So you can imagine if this could be reduced by more than half, it helps a lot. As I said, more precise reports, and the one really huge lesson learned is the trainings that the medical staff received. I think Tamara mentioned as well, and this is very important. And all of this was done with one supplier. The equipment was provided with one supplier, the training, and as well the softwares and the AI solutions. So very important in this regards in Finland. Another case that was used was a partnership in Vietnam together with Hanoi Medical University and Radiology Across Borders and Screen Point Medical. The problem was that the ladies in Vietnam, you can imagine there is a lot of, breast cancer is one of the most dangerous and most often case of cancer. And the topic was that this AI softwares that were used for the diagnostic imaging, they were trained on women from US and Europe. But the topic in Vietnam and with Asian women is that they have a higher breast density, the woman in Asia. And therefore, it was not fitted to the solution in Vietnam. What we did in this consortium is that we really evaluated mammographs of around 13,500 women, and they really kind of trained the system on the local patients. Sometimes, you have to think about this, and the biggest learning is this localization of AI that happened in this regards. And basically, the system was giving a score of probability for cancer of 1 to 10, so that the radiologist could focus on the cases, let's say, that are more dangerous, and the probability of 1 to 95 for the malignancy that of this cancer, dangerous cancer, so that they really focus on such cancer, patients when they're doing the imaging. So, as I said, the biggest learning here is the localized solution, which has improved efficiency in the case of Vietnam. Then we have the case of Turkey with laboratory diagnostic. It's a different area, maybe not so much for cancer relevant, but still some of these samples are being sent to the laboratory diagnostic. And these Mersin and Bilkent are very famous cases in Turkey, for that we have done Siemens Healthineers in these two big hospitals. How we leveraged on AI in this case was that we used this program that is called TeamFleet, and really this laboratory diagnostic streets, they were basically trained that as soon as maintenance was needed, a spare part or any kind of servicing, maintenance of the laboratory streets was needed, it was already signaling, so that really the process was so that the equipment was always in use and well maintained, and this has really helped as well in improving efficiency. That really the systems were constantly in use, and as well, of course, in cost efficiency, so that the laboratories, they were not losing too much time and costs and revenue if something went wrong. As you can see here as well, Mersin started with 5,000 daily results, and after 4 years, they have managed to have 100,000 results. So it is a huge topic, and really patients were being able, if they were admitted in the morning, that they could have had in the afternoon already the talks with the doctor, and they didn't have to stay over, especially if they were coming from the rural areas. So a huge advantage again that was being done through a PPP and that has implemented AI solution as well. Finally, I think this is one of the most interesting cases for me. It happened in Spain. It's a Hospital del Mar in Barcelona. The problem is with manual contouring which lacks of precision. So what they were thinking of in research and development between Siemens Healthineers and the Hospital University in Barcelona, they developed this automatic contouring to treat really the organs at risk, so that really they could focus on the organs at risk. And not only that, they were using as well this rapid plan for the treatment, so that it was personalized and adjusted the treatment as well. This is a program from Varian, which is as well a Siemens Healthineers company, so that really personalized care was developed for the patients. Yeah, so this is a huge advantage again: personalized care, precise therapy, time saving, and as well through the AI usage in this PPP or in this partnership, less waste was really managed, and which equals as well less cost. So a lot of benefits you can see from all of these 4 cases that have happened through a PPP that has leveraged on the AI solutions. So that were the use cases. I hope you have as well some learnings. As I was saying, in the recent past, I actually handed over my PhD topic, my PhD dissertation on a similar topic about leveraging of innovations through PPP in the healthcare sector. And I was really happy. I mean, I'm not going to talk too much about it. I was really happy that, especially in the healthcare, as healthcare is a social sector, that we were not only talking about cost efficiency, but we were talking about general efficiency and quality and so on, because this is a social sector. And as well, it was mentioned in that the result is that really access to know-how can be provided through the PPP in the healthcare sector. Yeah, and these are some challenges that I have as well identified besides the normal one from the literature. As I said, I'm not going to talk too much time, but one of the biggest learnings is as well, as Tamara mentioned, is that when you implement such a technological innovation, especially AI and digitalization, you have to know your region, you have to know your local requirements, your policy, what you need and what you want to achieve with it. Without it, I think there is not going to be a success, because there is no one-size-fits-all solutions. And very often it's a trendy topic. People are saying, or healthcare leaders are saying, let's use this and AI, without really knowing what they want to achieve. So really regions and countries are different. So first, when healthcare leaders are thinking about a public-private partnership that will enhance as well the AI leverage, they have to consider what they really need and the local requirements. I hope you enjoyed my presentation. If you have any questions, please write them in the chat, or please ask them. Thank you very much.
Thank you very much, Stefan. Your case studies were really compelling, and you showcase how PPPs can turn AI potential into a real impact. And your emphasis on context-specific solutions, on staff engagement are really insightful. I wanted to ask you maybe more specifically, you mentioned staff resistance as a challenge. In your view, how do we balance automation and clinical autonomy, especially in high-stakes fields like oncology?
Yeah, very good question. Very, very, very good question. And I've made the experience as well working at Siemens Healthineers. When you talk to some specialists, the doctors in the hospitals, and you tell them you're trying to sell them a new MRI system, a new CT, and they're saying, please, 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 please don't change this. I know how to. I've been doing this on this MRI machine since 10, 15 years, and I know how to place the patient and how to position him or her, and really I do the best images. And so this resistance is really there, at least in my experience, when I go talk to these specialist doctors, as I said, in my regular job. Yeah. And how I think that really what is very important is that, and what came out as well as one of the main learnings from my PhD as well, that you have to have open discussions and you have to involve the medical staff. Very often, as I said, the healthcare leaders, they have some ideas and the hospital administrators, but they are not involving the medical staff experts. And they are the ones who are on the front line, and they have to be involved in the process. Tamara as well mentioned that especially with AI and workflow, they have to be trained on it. And they have to, one important thing that I would like to add on top of what Tamara mentioned is the acceptance. They have to accept it as one of the tools that will enhance their work. So they will have their clinical autonomy as well to make decisions, but it's a co-pilot, as Tamara mentioned. It's something that helps them to enhance, to do faster decisions and better decisions, not only faster decisions. We are very often talking about more patients, faster decisions, and so on, but as well, they have to keep in mind that the quality is there. Yeah, so training is there, involvement of the medical staff, that actually is causing the acceptance from their side. And at the end of the day, I think that the human factor, this human factor, it has to be measured and kept in mind when we think about, when we consider PPPs that leverage on AI solutions or any kind of technological innovation. Thanks.
Thank you, Stefan. You mentioned you extensively researched through your PhD these problems. Did you discover additional challenges on benefits that are not very often mentioned in the literature?
Oh yeah, I think definitely. I mean, for the challenges, I mean, of course, that what is mentioned in the literature, such as fair share of risks and benefits, you know, everybody knows that in the PPPs and so on. But I think for the challenges, as I mentioned, one of the challenges which really came out from the experts, from the talks, is what I already mentioned: the involvement of the medical staff from the early stage in the PPP, when they consider the PPP, that involved the experts from the medical staff. One other as well challenge that came out is the expectation management. As I mentioned, really governments or healthcare leaders, they have to know what they want to achieve. So if they know what the expectation is, I call it expectation management, and what they really want to achieve and have clear KPIs, then it's much easier to communicate this to the partners, to the consortium, to the private sector that participates in the PPP. And this is one of the biggest challenges that came out. And this is something that came out, I think, as originally from this paper, from this dissertation. And as well regarding the benefits. If you look in the literature, as I mentioned, very often they talk about value for money, cost efficiency, and so on. This was as well included in my PhD dissertation. But the healthcare sector is a social sector. The name says it itself. It's for the people. And the social sector, it should focus as well on the quality. And I was very happy that as well the participants and that my studies have shown that PPPs that trigger innovation can really drive as well quality, and that they can improve the quality as well, and as well not only the cost efficiency, but the efficiency in general, the processes efficiency in general. And this is what is originality, I think, of my paper, that we are talking about the social sector that really through the PPPs can achieve better efficiency and more quality of it, which in my mind is very often something that is forgotten, because of course governments are talking very often about the budgets, about the costs and so on, and forget about this in the back of their mind. So yeah, thanks for these questions, Thibaut. Is there any other questions maybe in the chat or from somebody else?
Thank you, Stefan. I don't see any other questions in the chat. So I think for the moment we'll take on there and we'll go to the next speaker, Varun Goyal. To you, Varun.
Thank you, Devu. Thank you. And I'm just sharing my PowerPoint. I hope it's visible. Okay. So thank you everyone for joining this webinar, and it's kind of exciting webinar where we are talking about benefits and uses of digital health and AI in healthcare, which is a very growing and powerful area these days, because it is leading to increased access to healthcare in to the last mile. So my presentation will be short and it will be more focused on the kind of benefits and challenges we are seeing. So first, I will talk about some of the benefits we have seen while implementing these digital health and AI solutions. The first one is definitely, as we all know, in the chronic disease management, specifically the NCDs, the digital health and AI solutions, they have given us very much solutions into detection, screening, and also kind of a better management in terms of adherence to the drugs. So I think a lot of digital health solutions, they have benefited us in terms of monitoring and treatment of chronic diseases, and that ensures in future sustainability for our healthcare system. Second, people or patients, they these days use a lot of wearables, and they also use a lot of mobile apps to track their healthcare, and also they basically are taking their own decisions using these devices, and that's one of the great advantages of digital health, where patients are taking their healthcare seriously using these solutions and becoming e-patients. Uh, this integration of digital records, smart sensors, and AI solutions, it's all driving data. Like we're using this data, which is in billions of data points, and we are using this to make the decisions better, uh, whether these decisions are taken by a policymaker or by a healthcare provider or patients by themselves. So it's basically helping all kind of stakeholders associated with health sector in taking the data driven care seriously. Then definitely when we talk about hospitals or healthcare system and their better utilization, these digital health solution these days, you must be coming across a lot of digital health solutions, or which includes both hardware and software, but it's helping our staff, whether it is clinicians or paramedical staff, in such as like streamlining their scheduling, billing, documentation. Nowadays you have the AI usage in case of voice to text, and a lot of private hospitals in India, outside India, they are using these solutions for recording their like medical records basically, and which ensure doctors have time to look at the patients. Definitely, COVID-19 it act as a COVID-19 pandemic act as a catalyst towards these solutions, and from 2020 onwards, we can see the graph going up towards adoption of these initiatives across the globally. So, and also digitization has improved transparency and accountability. You can see how beautifully the data from various software or various data points are beautifully shown on some kind of dashboards. And these dashboards are being looked at by policymakers, by administrators, and it has improved transparency and accountability by the service providers at the last mile, and whether it is from the primary health center to a central government hospital or a medical college, everyone is accountable now because everyone's performance is being tracked using these digital health solutions. Then definitely with a lot of solutions coming up, a lot of new care pathways are also there, and this is also driving investments in healthcare, and it also brings innovations. A lot of people are innovating in health sector because digital health is driving investments in healthcare, and it is changing the care pathways, reaching to the last mile, to the marginalized population, to the population which is underserved. So I think digitalization is one of the key factor in driving the healthcare, also the healthcare cost, by improving lot of preventive cost, which is ultimately impacting our healthcare cost, where patients are not going towards seeking the healthcare by preventing a lot of diseases. Then lastly, as I told earlier, it's bridging the gap for rural population and underserved population, and like we can now do the screening of people at the community level using these devices, and a lot of devices are there already in the market, and they are testing, they are sending the reports to the clinicians, and they are providing treatment to the patients through teleconsultation. So I think this has greatly improved the reach of healthcare to the underserved population. I'll talk about a few of the challenges which we have all observed in digital health. First one is always a lot of software with fragmented electronic health records, because there are so many vendors we have seen across various countries who are developing non-software related to EHR, which are not talking to each other, and a lot of API integrations or CSV integrations are happening for sharing of the data. This results in when we are defining our algorithms for AI or digital health solutions, we are doing it on very less amount of data, because systems are not talking to each other. Though we are now increasing this interoperability function through various mechanisms, like we have now Ayushman Bharat Digital Mission right now in India, and through that we are trying such digital interoperability mechanisms, and in other countries also this happening. So I think this is one of the challenge we have seen, and it's kind of being acknowledged by the policymakers, and it is getting addressed now. Yes, there is a risk to the data security and like privacy of the patients. That this risk is there. A lot of data has been in control of various stakeholders, but then how it has to be controlled should be driven by our legal systems, which should be very strong, so that it should be penalty based, and if they are there, like we have seen in India, we have now data protection and DP, we call it as DP Act 2023, and it's allowing a lot of benchmarks for not for securing the data of people. Then third, we have seen the infrastructure gaps, which is already there in our a lot of LMIC countries, where we lack system-wise. So there are system-wise issues, whether it is broadband issues or whether it is issues related to the data centers, and also about the power. So a lot of these issues are there, which is not allowing us to scale our solutions to the last village level. So that's again, and government definitely is addressing such solutions, such gaps these days, either through directly or through using the public-private partnership mode. Then we have definitely there is algorithmic bias we all know in AI, where we have more focused databases for training the system using certain key population, which are basically like urban based or not so like marginalized or underserved population, which should be factored in, so that these systems which are meant for public should be equitable in nature, so that everyone is getting benefited from it, not just a specific group of people. Then we do have regulatory complexity related to AI frameworks, and it is all based on which level we are at right now across different countries, and it has resulted into a lot of new solutions. They are getting not being moved forward due to these issues. And definitely the digital literacy of people, of definitely those living in the rural areas, and those biased by age groups, and also by the education. So those are the key populations, I think, which are getting deprived of benefiting from such solutions, and it's kind of a challenge for scaling these kind of solutions. I have certain like as part of the next steps, I have certain like based on my experience of implementing two large digital health solutions for Government of India and for general public. What I have seen is that uh, we, depending upon whichever country we are working, and our solution should be locally adopted for the local environment and the users. What I mean by environment is everything. Like we should be looking at a person who is living with what kind of family, what kind of area, whether it is rural, urban, whether it is tribal, or whether it is like a well advanced state or less advanced state. So it's kind of environment, and how other parts like mobile connectivity and kind of other requirements for overall adoption of the solution. I think we should be looking at that, and also the users' capabilities, how well the users are. Like we were implementing one solution in India for giving for patients to give feedback on their health services in all public health facilities in India. And when we started, like this was one of the idea which came, like we should develop a mobile application. But when we did the survey, we found that most of the people are living in rural areas, like 40 to 45, 40 to 50%, and they don't have access to smartphones. Most of them, they have access to feature phones. So we came up with a solution which is adopted, which can be adopted by everyone. So it has to be a multi-pronged approach where a system is getting being used through feature phone as well as smartphones. So that's kind of like human-centered design we should all look for while developing this kind of digital health solutions. Then, as I talked about, the digital literacy and access, which needs to be improved by reaching to these people and making them literate about digital health solutions, by making them part of the digital health solution development as well as implementation, so that they are with us throughout the cycle and they are working along with us in developing these kind of solutions. Then contextual implementation. The implementation of such solution has to be like the people who are going to use it or who are going to implement it at the last level should be properly trained. And the implementation has to be incremental, so that in the first go we should not think of a scalable approach. We should pilot it, learn from it, and then do some changes and scale it. And then the ongoing technical support we need to be providing, so that there is no lag in the usage of the system. So that kind of a contextual implementation. Then I was going through this paper published in 2024, where they talked about digital determinants of health. So this particular paper said that the digital determinants of health should be talked in relation to social determinants of health. And while defining this, we always look at these 9 digital determinants of health, which is ease of use, how a particular user is perceiving its usefulness, the interactivity between the solution and the user, the digital literacy of the user, the solution accessibility, availability, and affordability for the ultimate user, as well as for the person who is developing it. The algorithmic foundations, so like what kind of data we are working on, whether it is inclusive in nature and equitable in nature or not. So because whatever we are developing is for everyone, not just for a particular tranche of people. And how working in a generalized mode, but how well it can personalized also for a particular category of people. And then the last is we all know data poverty. Like we all know we have data shortage or information asymmetry due to these fragmented data sources. So how we are going to solve that issue is all these 9 determinants of health. I think we should all be looking at while developing our solutions. I stop here. I look forward to any questions, but this is overall. I just wanted to touch base upon on some of the areas where we should be looking at while developing these solutions for LMIC countries, where we are finding challenges due to all aspects, whether it is for the user, the policies, how we are including people in our design as well as implementation. So this is all about just I wanted to touch base upon. If we know about this, but I just wanted to remind everyone about that. Thank you. Over to you, Thibu.
Thank you very much, Varun, for this comprehensive overview. I think you showed very well how AI has the power to democratize care and address systemic inefficiencies. But at the same time, there remain some hurdles like interoperability gaps or bias. And I believe your roadmap offers a really pragmatic path, especially for developing countries. As a follow-up question, I would like to ask you how you see the interoperability challenge. You mentioned EHR as a barrier to used
Yeah.
to harmonize the database before full digital transformation.
No, can you repeat? Actually, you cut out in between. Can you repeat the question, please?
Yeah, I wanted to ask you how what strategies developing countries could use to facilitate interoperability and harmonize a database to implement digital transformation.
Okay. Yeah, so definitely this fragmented EHRs is based on how we are developing these solutions by different vendors within a country where we don't have national HIS standards to follow, and these systems are not talking to each other. Like in India also, we do have national level systems, but at the state level, we also have certain other systems state to state which are capturing these data sets, but sometimes they are not talking to each other. So what we think is that the best solution here is a approach where it should not be very much costly for the country. It should be a low cost process. Like suppose we can start with the listing of these solutions, and now sometimes we have paper-based data entry also for EHRs in most of the low-level public health facilities up to district hospitals. So in such cases, we can start converting them into electronic databases slowly in a staggering way, so that it's not a burden for the neither for the data entry people as well as for the to the exchequer. So how well we can standardize our templates, which is driven by some kind of a national policy, and slowly we are moving towards paper-based to computer-based solutions, and then also like sharing of data, which can easily be done through. Definitely, there are two ways: either we do through API integration or through CSV integration. But we can start with the CSV-based integration, which is not that much costly as compared to API, and then we can slowly shift towards API once we have systems talking to each other, when we have compared all the data parameters and mapped them against the standard benchmarks. So in that way, I think we can slowly move towards the databases which are talking to each other, or we can have, or we can also, third is we can also use of open source EHR. So wherever which country is not using EHRs right now, they have paper based, they can use open source EHR systems available, which are already complying with HL7 and OMOP kind of standards. And such I think solutions can help this kind of low cost EHR compliance, and moving towards a national level EHR integration for better AI solutions.
Thank you, Varun. I have a
Thibaut,
question,
if I may, just on this one, Varun, thank you so much for this. The algorithmic bias, I think, is a very interesting one, because we were looking at a project for using AI as an assistant for reading radiology reports. And what emerged from that is the amount of data that you have to feed in to stop this algorithmic bias. Because issues like, I see Stefan is nodding his head, issues like gender, of course, ethnicity, age group, and so on, are all really quite vital when it comes to when it comes to actually taking those readings, putting them through the algorithm, and having enough data that relates to each kind of segment and sub-segment. It's a big challenge to do that. And then when you look at the interoperability issue as well, it all goes. Just really wanted to make that as an observation rather than a question, because I'm conscious of time. Thanks. Back to you, Thibaut.
Yeah, thank you, Nasser. That was actually my question to Rome. How can we address the bias and make sure that underrepresented populations get equitable access to AI technology?
Yeah, it is a very difficult question, and because we need to take care of funds also. But sometimes, like if we have to do it, ideally it should be along with the people. We need to develop such kind of solutions. So if we are developing any kind of solutions, which is, let's say, for screening of some kind of a disease where we are using AI, then we must be designing these solutions based on a geography where we are including the population going into living in the rural areas, or and then segregated by all kind of aspects, whether like it's a woman who is a woman subgroup whose mobile are basically taken care by husband, and they don't have say in case of using the mobile. So those kind of population be part of the solution design. Then we have like the sexual minorities who also get not to, because they have their own challenges or trust issues with the healthcare system. So how to involve them if something is being developed for such kind of population. Then we also are looking at the age-wise issues also, like old population, then education. So it's basically how well like we are sure about what we are going to develop and where we are going to implement. And if we are implementing it for rural population, then we are going there and making them part of the system. Then and then how we are using the community health workers. Basically, that is the main subgroup living in the rural area, who is ultimately the last healthcare provider, and how well we are using them so that they are acting as a mediator between us and the user of the solution, and then how they are helping us in building the trust for that particular user to be part of our whole solution development as well as its implementation. Then it's also how well we are like incentivizing the population to be part of the solution development. So what kind of incentives you can do, like you can do financial incentives, or you can give certain other benefits, like if they are part of the solution, then you will be giving them like certain kind of benefits related to their targeted healthcare screening using that solution, or linking them further with the tertiary care healthcare providers. So basically,
I think that's great, Varun. I think
yeah,
that's fantastic. I think we just need to be conscious of time.
yeah,
Thibaut?
yeah.
Yeah, thank you very much, Varun. And last but not least, we're now going to our fourth speaker, Myriam Mesfaoui,
Thank you.
who will introduce additional insights. Thank you very much, Varun. Up to you, Myriam.
Okay, hi everyone. Let me just share my screen. Okay. Is that okay? Okay. So, hi, good afternoon, everyone. Thank you again, Nasser and Thibaut, for having me as part of this second session. In part one of this mini series, I focused on the real-world use cases of AI in remote monitoring for chronic disease. So and it was not like just to show what exists, but it was mainly to draw strategic lessons from the field. And today I would like to build on that foundation and take this conversation, one step further. So I wanted to start with this slide I used. It was the final slide of my presentation last time, and especially for those who couldn't attend, because it sets the foundation for what I want to explore today. So a lot of real world cases, not only the 3 use cases I presented last time, showed a real clinical value, but the outcomes were not driven by the technology alone. Instead, there is like 3 enablers consistently made the difference. As you can see, the trust, the alignment, and the local fit. So from my perspective, the challenge is no longer just to prove that AI can support remote monitoring or remote care in general, but to design models where this support can be sustainable, inclusive, and system integrated from the beginning. So this is what I want to talk about today. And I want to share with you this model use case I've been working on. And it aims to serve as a scalable framework for implementing AI-enabled remote monitoring or remote care in general, especially in low and middle income countries. So this model, as Tamara was saying, is not, and it is not supposed to be a copy paste from a single context. It's shaped by what we've consistently seen in the field, the success factors that enable scale, and the limitation that often hold it back across different systems and different countries. So at the center of this model, as you can see, is the patient. And the patient not just as a data point, but as a human being whose health journey crosses clinical, digital, and all social spaces. Up. So first, we need a robust digital infrastructure and interoperability. AI needs high quality data, but it also needs data to flow. That means secure, interoperable systems that can actually, as Varun was saying, talk to each other across platforms and the different levels of care. The second pillar is that the AI layer itself must be embedded in a meaningful engagement tool. Because we are not building this tools or this solution for engineers, but we are building it for nurses, doctors, patients. And so the interfaces, for this solution must be intuitive, actionable, and adapted to users' needs and skill. The third, it's the clinical integration, and the success depends as well on this clinical integration, meaning that the technology should enhance care and not disrupt it. This means aligning AI tools with existing workflows, supporting decision making, and avoiding as well what we call the digital fatigue for provider. And the fourth, and for me the most crucial pillar, is that we need a system readiness and stakeholder intelligence. So because even the best designed model can't work if the broader system is not ready. And when I talk about broader system, it includes governance, policy alignments. Michael, Tamara, and Stefan, like everyone highlighted this different areas. So I was saying policy alignment, financing as well, and most importantly for me, trust and collaboration between actors. So I would like to go a little bit deeper on this fourth pillar, because there is a lot of projects that struggle and where stakeholder center design makes all the difference, and it's also because it's the field I specialize on. So, sorry. So this pillar is not only about the technology itself. It's about the people, the governance, the alignments that determine, sorry, whether innovation will scale and last. So we begin with the deep stakeholder mapping, not just listing and identifying institution and all the stakeholder involved in a digital health AI health project, but truly understanding who holds influence, where are the tensions and friction points, and where could alignments and alliances emerge. And then come the system maturity assessments. And for this system maturity assessment, we can use structured tools that exist, like the Global Digital Health Monitor that was co-developed by WHO and ITU, which is the International Telecommunication Union. And it's a government grade maturity assessment platform that was developed, and it's using 23 indicator, and it goes from governance and policy to infrastructure to workforce readiness, equity, and even AI integration, and it helps governments to assess how ready a system is to absorb digital health intervention. And importantly, it's not just about national strategies. Countries can use this global digital health monitor finding to trigger investment, align partner, build trust across stakeholder, and it can be relevant for a project level design, not only in a national or strategic level. And in the context of PPPs and the AI-enabled care, this tool, the Global Digital Health Monitor, helps create a common language between governments and partners, making it easier to align priorities, build accountability, and design scalable solutions to match the local reality. I think Dr. Tamara was insisting about this, the fact that it has to match the local reality. So, but even if we have strong systems, it can fail to adapt if we don't understand something crucial. It's the human experience. That's where the adoption studies come in, and they help us to explore the emotional and structural barriers that prevent uptake even when the system is mature and the technology is sound. So yeah, Varun talked about it, and everyone talked about the common adoption barriers, especially across many low and middle income countries, like the lack of trust, digital literacy, the workflow disruption, the fear of, I was saying, yeah, the common adoption barrier, like unclear benefits for providers or the fear of job displacement. But the adoption is never generic. It's deeply contextual. That's why we need to study adoption at the level of each specific project or solution. These studies will answer to questions like what builds or breaks trust in particular setting, what users, whether patients, nurses, or decision makers fear or resist or misunderstand, and what incentives, Varun was talking about, what incentives or behaviors will actually drive sustained engagement. So we can draw from different structure frameworks or models like the technology acceptance model. There is like a more recent digital health specific one I like to use, for my own research, is the NAS framework, which is non-adoption, abandonment, and challenge to scale up, spread, and sustainability of health and care technology. So that said, even the most robust model must be adapted. I'm insisting on this. My colleagues did the same. Because it has to be adapted to the specific context of each project, because adoption is not supposed to be something theoretical. It's shaped by perception, relationship, and local realities, and can be really fragile if these are not understood. So once we have built this intelligence, we move on to designing the engagement and governance strategy. For this, there's not a lot of framework, but one of them is the UNICE stakeholder engagement guidelines for PPPs, because this can help create legitimacy, shared accountability, and clear decision-making pathway, especially when innovation in PPPs spans public and private actor. And speaking of private actors, you can see here that their role goes far beyond only funding. In this kind of ecosystem, and based on the digital health monitor and some real world cases, the private sector can act as well as tech building tools and platform. It can be an implementer, ensuring reliable and real world deployment of the solution, analytics partner, managing dashboard and translating data into insights, and even co-governor, helping define ethical, secure, and sustainable standard. So that's why strategic alignment, it's not just something helpful, but it's essential to build that. So in this complex multi-stakeholder, multi-actor environment, we need more than coordination. We need what I like to call the invisible architecture. This architecture that can align people, system, and purpose from the start. So as I talk about this UNICE guidelines about stakeholder engagement, and this document, which is still currently under finalization, it highlighted that the effective stakeholder engagement strategy must be intentionally designed from the beginning. So that means defining shared goals, clarifying responsibility, and establishing mechanisms to build trust must be done before implementation begin. So, and this is particularly critical in public-private partnership, because PPP are not just about sharing resources. I was saying they are also about sharing risk, co-creating value, and building system-wide alignment across diverse sectors. When this foundation is in place, PPP can really become a powerful vehicle for scaling innovation that is not only effective, but also inclusive, sustainable, and locally grounded. So, okay, I'm conscious about time. I will just leave you with these four key takeaways. The first one, that AI-powered remote monitoring can work, but only when systems are ready and when technology is trusted. Second one, that PPPs can structure innovation, but they must be inclusive and deeply grounded in real world needs. The third one, that stakeholder engagement, it's not, I would say, just a side activity, it's a core design principle. And the last one, we must design not only for adoption, but for ownership, because that's what truly makes innovation sustainable. And I will end up with the message you can see on this slide, that AI is not just a technology, but it's a catalyst for redesigning how we partner across different health systems. Okay, thank you. I'm conscious that
Thank you very much, Miriam. I think your presentation illustrated quite well how we need a human-centered approach to ensure the success of
Yeah,
the implementation of the technology,
totally.
and to make sure that we get the buy-in of the stakeholders.
Totally.
This technology. So maybe if you could elaborate on how in practice we could help to build trust with patients that are skeptical about AI to facilitate the adoption of the technology.
Yeah, thank you, Thibaut, for this question, and thank you because I'm happy that you brought trust up, because it's I was saying it's not just a side issue, it's the foundation. And since you were talking about patients, I would start by saying that patients are not just recipients of care, they are key stakeholders in any AI remote care model, or in not only remote, like enabled care model, not specifically for telemonitoring. They play a central role. And that means we need to design with them, not just for them. That's why I was talking about co-creation with all the stakeholder, including, of course, this the key stakeholder, which is the patient. So in fact, the kinds of trust issue we see, whether in chronic care or in broader digital health setting, they're often the same. So across different populations, skepticism usually comes from these three things: the low health and digital literacy, the fear that AI might misuse their data or replace human care, and the third one, it's this feeling of losing control over how technology enters their care journey. So they are not just chronic patient issues, but they are, I would say, human issues, and they apply to many other users, the caregivers, older adults, and the served population, and even health professionals themselves. So how we can build this trust? I think from what I've seen, these are the most effective and the practical trust building steps, I would say. The first one is to be transparent about how data is used, stored, and shared, and communicate this in a clear and non-technical language. The second one is to involve patients or users early on, for example, through advisory board, pilot testing, or co-design workshop. The third one is to roll out AI gradually, blending tech with human support, especially at the start, so users feel supported, not replaced. And importantly, to adapt tool to the local context again. Interfaces, languages, visual, the tone of voice, everything should feel familiar and respectful of the user environment. So we also need to train, and Varun talked about it, to train the frontline actor like community health workers or nurses who can act. Varun, I don't know, you said it in different words, but they can act as trusted bridges between the technology and the people. So in short, I would say trust doesn't come from feature, but it comes from process. And if we want AI-enabled care to work, not just in theory, but in real life, trust must be built by design, not just assumed by default.
Thank you very much, Miriam, for this comprehensive answer. We have only a few minutes left, so I will open the floor if there are questions
Yeah,
from the
Thibaut,
audience for the
there is
moment.
a question. I'll just put it in our chat. So the question is from Mahesh Singhai. Thank you, Mahesh, for the question. And he says that a key aspect of PPP projects being long-term concessions is the use of established or proven technologies. And he's asking that, will this bring a hindrance of using AI on healthcare PPP projects? I think there's a starting point that you may need to reconsider in that kind of question, Mahesh, because when you look at the traditional infrastructure projects, a roads project, for example, with a big capex, the reason they turn into long-term concessions is because you have a high capital expenditure associated with the investment in an asset that has a long depreciation profile. A road or a building depreciates over 40 or 50 or 60 years. And therefore, to make the annual payments affordable, there tends to be a long-term concession. So you need to kind of move away from that thinking when you look at technology and AI type PPPs and think about the longevity of that technology or that asset that's part of that technology. And therefore, what you'll find is that the partnership arrangements that go with technology and AI solutions have a considerably shorter time period than the ones that you're traditionally confronted with, which are to do with the long-term ones. Stefan, maybe from your perspective, because you deal a lot at Siemens Healthineers with technology type partnerships, perhaps you have a perspective on that as well.
Yeah, definitely. I mean, I agree with you, and I mean, with the capex, that it's basically, it used to be traditionally a longer term contract, but when we think about AI and technology, it's definitely something that it needs to be established from the beginning, and the term of the contract must be considered as well, so that the government really knows what they're willing to achieve with this. And one, I think, important messages as well, as much as it's possible, especially in the policy, the flexibility in the adjustment, of these requirements. I think this will change probably in the future, because this is changing, as I said, with the dynamics of the society that is going on, with the dynamics of innovation. So as well, I think that PPPs in this regards as well have to bring some sort of flexibility in the adjustments towards these requirements, as mentioned.
Yeah, great. I don't see any more questions. There's something else in the chat. Let's have a look. I don't see any more questions, neither in the chat nor in the Q&A. Back to you, Thibaut. If you want to do some, we have about 4 minutes left.
And I have a very broad questions for the speakers who would like to answer, but where would you see the biggest breakthrough in the next 5 years in the area of AI healthcare? Who would like to answer?
Varun, you want to start?
Yeah, sure. So
Don't take all 4 minutes.
No, I'll give one message. Yes, it's truly, I think in next 5 years, the use of generative AI, large language models for I'll speak about pharma, because I'm right now working in pharma industry. So in pharma, we do a lot of health economics work, and which is cost effectiveness of introducing a new drug into market. And so for that, definitely this generative AI using large language model, and also right now agentic AI is also a new concept being added, where it is understanding your like tone and your emotions. So I think those kind of factors is very much required right now in pharma industry. Yes, it's growing a lot, and we are seeing that it will be used for like systematic literature review, for health economics work and all. It will be of a great use in next 5 years, especially for pharma. Yeah.
Who wants to go next?
Anyone else to address
Yeah.
this question?
One more topic, maybe. Yeah, I think maybe just one thing to add as well from what Tamara mentioned and presented. I think that as well robotics will be a huge topic. It's like with all of this going on, I think in the past years there was a try, and it's still a trend that with robotics, things are being changed. It's a game changer. So I believe that this is going to be this could be a huge breakthrough in the future, you know, as well with robotics treatment and so on. So this is something that I'm looking forward to, especially in the healthcare sector. Yeah.
Thank you, Stefan. Nasser, if you want to stick to the schedule, I think you need to take the floor.
We have one more minute. I think Miriam wanted to.
Yeah, I would just like in 2 words, because it's something that means a lot to me. We talk a lot about interoperability issues, and this is like really, well, I know how we say in French, le cheval de bataille, like it's the main challenge, you know, for implementation of digital health. But we talk about interoperability in a technical part, but I like to use this term. It has to be also, we have to be conscious about this issue, which is the human interoperability. So if we can architecture this human interoperability as well, it can be a breakthrough for the next year. I wanted to use this term because I think it's like really something foundational, not only the technological interoperability.
From my end, I think the biggest breakthrough will come from actually countries and health systems understanding that data, and especially data relating to the individual, to every citizen, every resident, is actually a crucial determinant into the health system. And starting to capture that data in electronic health records, having a health system that actually interacts with epidemiological data and everything else to really better understand the health of the nation, because there's a lot of discussion now about preventative health, about personalized medicine and so on. But you can't hope to make real inroads into this if you don't have the proper data. And we're not talking here about this kind of thing for the select few that can afford the personalized medicine. You need to kind of use it at a public health level. Thibaut, thank you so much. That was a very nicely curated and moderated session. This brings us to the end of the second webinar in this mini-series. The third one will be hopefully sometime in September. We'll kind of coordinate the dates. We thank the audience for joining. We understand we're kind of somewhat in the holiday period. But all of these webinars are recorded. So if you've missed it or you heard about it, or you know that a colleague or a friend wanted to attend but couldn't, then please let them keep watching out on LinkedIn for the recordings. And we'll bring this one to a close. Can I just ask the speakers to give a nice smile, because I want to take a screenshot. Okay, that's done. Just catch it on my thing, and we're good to go. Thank you very much. We can close this panel now.
Thank you very much, everyone. Thank you, audience. Thank you.
Thank
Thank
you.
you. Bye-bye.